I want to welcome everyone to Grand Rounds today. I'm Dr. Barbara Fitzgerald, the Associate Residency Training Director, and it's my pleasure, in the absence of Dr. Erica Ruth, the Addiction Training Director, to introduce our speaker today, Dr. Amanda McDonald, one of our soon-to-graduate Addiction Fellows. I asked Dr. McDonald how she would like me to introduce her, and she said, "Keep it simple." So I will. Dr. McDonald is a graduate of the Pikeville, Kentucky Osteopathic Medical School, and she came to us and has completed 4 years of an adult residency, recently completing her boards to become board certified. She will be leaving at the end of June and has accepted a position in private practice in Sarasota, Florida, which she's very pleased to be going to participate in. This follows a brief time where she will be working at Eastern State Hospital as a locum tenens as she makes her way toward Florida. Her topic today, an introduction to osteopathy, came about as a result of a presentation she made on one of her service sites, and her colleagues expressed a great deal of interest and also prior ignorance as to how osteopathic medical training was different than our allopathic medical training. Since we are attracting a larger and larger number of osteopathic applicants and graduates to our program, I'm actually looking quite forward to this topic today, and I hope that we all will leave here in a much more enlightened mind about osteopathic medicine. So it's with pleasure that I introduce to you Dr. Amanda McDonald.
Thank you, Dr. Fitzgerald. Today we're going to talk about osteopathy in very general introductory terms. We'll review the history of osteopathy, introduce the principles and their relevance in psychiatry, learn about the structural exam, become familiar with OMT, and also talk about cranial osteopathy. So the father of osteopathy is Andrew Taylor Still. The birth of osteopathy occurred in 1874. After he worked in the Civil War as a physician and lost 3 children to meningitis, Dr. Still decided to go on an intellectual journey to find a better way of practicing medicine. So he developed this holistic philosophy, and it focused on the musculoskeletal system. And he utilized manual techniques that are now known as OMT. The first school of osteopathy is in Kirksville, Missouri. It's still there, it goes by a different name now. Started in 1892. And the emphasis was on preventative medicine with the understanding that the body has the inherent ability to heal itself. Oh, yes, sorry about that. So there are now 33 osteopathic schools in the country, and there are 96,954 osteopathic physicians. You can see the breakdown there. Most of us are under the age of 45, so we're a fairly young group. A lot of primary care emphasis is placed in the educational process, so many people end up going into primary care. But when you look at the specialty breakdown, you see a lot of surgical specialties and then also psychiatry there at the bottom. There's a map with all the osteopathic schools, their geographic locations. The curriculum includes everything that is taught in the allopathic curriculum. On top of that, there is a class called Osteopathic Principles and Practice. And you get over 500 hours of training in your first 2 years in that specialty. And then some, not all, but most will require you do a clinical rotation in OMT. So there's also an undergraduate medical fellowship that you can do, and that's kind of what I stumbled into at Pikeville, where there's an additional year built into the clinical curriculum, and there is a stipend provided by the national organization. It's a really great opportunity to really delve into treatment and practice your skill. We also have a corresponding exam to the USMLE with the same parts, and it's essentially the same material except for the osteopathic stuff is added in. We have a match that's similar to the process that allopaths would go through. You can participate in both, but if you match in an osteopathic match, then you're automatically withdrawn from the allopathic match, and so that occurs beforehand. There are programs for all specialties. They are not geographically distributed equally. They're pretty heavy in certain areas where osteopaths have been for a long period of time, like Michigan, Ohio, Pennsylvania. We do actually have 31 positions here in the state now, which is a bigger number than I expected to find. There are 29 primary specialty boards with 77 subspecialties. And if you go through an allopathic residency, you can still go through an approval process and be eligible for the osteopathic board if you want to. They still have oral boards, so I'm not sure that that would be an attractive option for a lot of people. Some states have separate licensing boards, so if they have a segregated board, it's no different. It's just a different group of people who are licensing you, except for those 4 states that are listed there, which require you to do an AOA internship in order to get licensed there. That has the origins of that are kind of specific to each state, but there is an approval process if you didn't do an internship that was osteopathic that you can go through, and then you can get licensed. So the philosophy is really something that differentiates, I think, the two groups of medicine practitioners. And as much as the osteopaths, we have our own oath, and you can read through that on your own. It's kind of lengthy. There was also a consensus declaration put forth in 1953 when there was a big convention, and some of these things were formalized for the osteopaths. So one of their statements was that health is based on a natural capacity of the human organism to resist and combat noxious influences in the environment and to compensate for their effects, to meet with adequate reserve the usual stresses of daily life and the occasional severe stress imposed by the extremes of environment and activity. So these are the 4 principles. The body is a unit. The person is the unit of the body, mind, and spirit. The body is capable of self-regulation, self-healing, and health maintenance. Structure and function are reciprocally interrelated, and rational treatment is based upon the understanding of those basic principles of body unity, self-regulation, and the relationship of structure and function. So going back to what the APA would say about psychiatry, they say the psychiatrist serves as the medical expert for the mind-brain-body interface, and they define psychotherapy as a systemic treatment method in which, during regularly scheduled meetings, the psychiatrist and patient discuss troubling problems and feelings. So that kind of ties back into those daily stresses and those extreme stresses that people experience, and this is something that is emphasized in your educational process that you're taught to be more considerate of, which is probably an emphasis that is not placed in allopathic training. So what are we learning in those 500 extra hours of that class? Well, we learned the osteopathic structural exam. So we are looking to identify somatic dysfunction, which is a term that's fairly familiar to most osteopaths, but is probably not very widely used among the allopathic community. Somatic dysfunction is defined as impaired or altered function of related components of the somatic system, skeletal, arthroidal, and myofascial structures, and their related vascular, lymphatic, and neural elements. So when we do the exam, what we're looking for, some of the findings that we're looking for when we're observing and palpating are tissue texture changes, asymmetry between bilateral structures, restriction of motion, both passive and active, and tenderness, which is subjective. So there are things that are known to be associated with acute findings, like an injury recall, obviously, in the history, acute or sharp pain, warm, moist, inflamed skin, vasodilation, muscle spasm, sluggish range of motion, boggy, edematous, soft tissues, and then chronic findings such as dull, achy pain, paresthesias, dry scale skin, regional sympathetic hyperactivity, limited range of motion, and muscle contracture with doughy fibrotic soft tissue. So we'll do a dynamic and a static assessment of the patient in various positions. Initially, you're just doing a screening exam, and then if you find anything, you'll do a segmental exam. So when we observe gait, we're looking at things like the heel strike, the arm swing, body carriage, head carriage, pelvic motion, all the details. You'll obviously do a general appearance scan and then look at the patient and their curvatures, the alignment, whether they're kyphotic or lordotic, and then also asymmetry. You can see in the picture, looking at the scapulas to make sure that they're symmetric. We'll do tests for range of motion, look for hip drop. The standing flexion test that you can see there is monitoring of the PSIS to assess the pelvis and its motion. Squat, of course, is a good way to check range of motion. The SITA test, which assesses the sacrum and the pelvis and the paravertebral muscles. You do your screening of the thoracic and the cervical spine in that position, and upper extremity motion testing. You'll have the patient lay supine. You'll do your segmental exam of the cervical region if it's indicated, and then check rib motion and some other static findings like the ASIS. Lower extremity motion testing, the passive testing of the range of motion there, and then the patient lies prone, and there are some other range of motions that are tested of the lower extremity, and then segmental exam of the thoracic and lumbar areas if that's indicated, as well as assessment of the sacrum, PSIS, and the cranium, which we'll talk more about. Posterior superior iliac spine. So when we're talking about the spine, the palpable landmarks that we really use are the spinous and transverse processes. And we are taught the principles of physiologic motion. They're Fryette's rules, essentially dictating what the findings are going to be if you see something pathologic in a neutral spine or in a flexed or extended spine. So the first principle is when side bending from a neutral position, so the spine is not flexed or extended. Rotation of the vertebral bodies will follow to the opposite direction of the side bending. And then principle 2 is when side bending from a non-neutral position, rotation must precede side bending to the same side. And then 3 is motion introduced in one plane, limits and modifies motion in another. So here you see an example of a type 1 mechanic with the little black dots representing the spinous process. And this is an example of a flexed dysfunction to each side there. And usually if it's a lesion that occurs in the flexion or extension, it's going to be just one segment, whereas in type 1, it's a group of segments. And then there's a depiction of the cervical spine with Fryette's third principle. This is a depiction of the sacrum. It's commonly depicted like this in our classes and teaching the motions of the sacrum that can occur. So you'll see the axes that are there. There's a vertical axis, no real motion there. And then the transverse axes, B depicts the cranial motion that can occur, which we'll talk more about later. And then C is the flexion extension axis, and then D is the axis that you'll get the pelvic innominate rotation around. And then the oblique axes we'll talk more about. So this is just a depiction of normal gait mechanics with the sacrum. When you walk and take a step forward, your weight shifts to one lower extremity, right? So lumbar side bending is induced on the weight-bearing side, as you can see, and it pins the upper pole of the sacrum on the same side. So the free lower extremity carries the sacrum forward, rotating it around that oblique axis that we saw in the last slide towards the weight-bearing lower extremity. And then the lumbar spine will rotate to the opposite side if the sacrum is neutral. Sacral dysfunctions are usually diagnosed using the sacral landmarks and motion testing. And the dysfunctions are described as either physiologic if they occur around the normal axis of motion, or non-physiologic if it's not around a normal axis of motion, so like a shear, which would be traumatic in nature. There are a variety of modalities of OMT. Osteopathic manipulative medicine actually became an official specialty that you can get boarded in 1990. Somatic dysfunctions are named for their freer motion, so this can get a little confusing. But if the spine is neutral and lumbar segments 2 through 4 are side bent left and rotated right, it would be written as it is there, L2 through 4 in SLRR. So that's just kind of the way we would document that on a chart, our findings. And that means that L2 through 4 is limited by a pathological barrier. So something stopping that motion. Range of motion is restricted in right side bending and left rotation at those segments. Treatment techniques are either direct or indirect, and this is based upon whether or not that barrier is engaged. So if you're doing like an indirect treatment, you would be engaging the motion in away from the barrier. These are direct techniques. HVLA is probably one that might be most familiar to the non-osteopathic world. This is the crunch or the crack sound that you hear people talk about when they're manipulated. You usually get that with the thrust techniques. The still technique at the bottom you'll see is also included in the indirect techniques, and that's because it includes both. So that is the technique that I will talk about. But usually the indirect techniques are more gentle and used in cases of more comorbidities with medical issues and concerns. If somebody's fresh out of an accident and they've had a lot of trauma, you don't want to do a lot of direct techniques. You want to use more indirect. So let's talk about the still technique. It's actually one of my favorites. And it's a passive technique, so the patient doesn't have to move or just, essentially sits there, lays there, what have you. It was first described and demonstrated by Dr. Still, but it wasn't actually formally put into literature and writing until 1996 when Dr. Van Buskirk investigated it, organized it, put it into an academic paper, and wrote the manual on it, essentially. So I've actually had the honor of being one of Dr. Van Buskirk's patients, and he's fantastic if you ever get down to Sarasota and need any treatment. So this is an example of a treatment, a still technique treatment for someone who has a cervical lesion, say C3 is extended, side bent and rotated right. You would stand in front of a seated patient. You always monitor the area that you're manipulating. So that's what you see there with the left hand. And the operating hand is on top of the head there. So the patient's head and neck are extended, side bend, and rotated right until the tissues in the affected segments relax. That's an indirect position. So you're taking it towards the way that it's stuck, if you will. This lady has her cervical spine extended at that segment. So using the operating hand, there's a force that's directed towards that segment from the top of her head there. And it's a very gentle force, less than 5 pounds, where you're like, how do you know you're applying less than 5? This is something that we practice over time. We certainly get to practice on each other. That's where it starts. And so your partner is very aware of what it feels like to be manipulated by, say, the professor versus you. And so if you're giving a lot more pressure, you can always give feedback to your training partner, if you will. And so it's just something you learn over time. So in this situation, the operating hand would rotate the patient's head and neck through a neutral position and move towards the restrictive barrier, which is a direct position. And as the segment passes the original barrier, you may feel a release, hear a release, or not. But after the treatment, you always reassess to see if it was effective. So that would be the last step. So next we'll talk a little bit about osteopathy in the cranial field. This is probably one of the more complex topics that we encounter in OPP. This was described by William Sutherland, who was a student at the American School of Osteopathy, and he noticed the unique articulations of the cranial bones. He observed that the CNS, CSF, dural membranes, and cranial bones with the sacrum function as a unit. He called this unit and its associated movements the primary respiratory mechanism. So just to refresh everybody, there's a nice picture of all the cranial bones that you can see from the anterior. And this is a depiction of the conjoint of the sphenoid bone and the occiput, which is a focus in cranial osteopathy. Another depiction for you. So the primary respiratory mechanism has 5 components: the mobility of the brain and the spinal cord, the fluctuation of CSF as it circulates through, reciprocal membranous tension, which is like an inelastic rope formed by the dura mater, which attaches at the foramen magnum, C2, C3, and S2. So that's how the sacrum gets pulled into this, right? And the mobility of the cranial bones themselves, the gliding, rocking, and shearing motions that can occur even at the smallest level between the cranial bones, and the motion between the sacrum and the ilia, like we talked about earlier. The cranial rhythmic impulse is the palpable manifestation of the PRM. So this has been measured. You can also feel it if you have good palpatory skills and some training. Normal CRI is like 10 to 14 cycles a minute. Lots of research has been done about what can cause an alteration in the CRI. Stress, depression, chronic fatigue, chronic infection can depress the CRI. CRI can be increased by exercise, fever, and cranial sacral OMT. Research has shown that CRI is low in TBI patients and low in depressed patients. One of the most consistent and well-researched phenomenon with abnormal CRIs in infants with excessive crying. If they have an abnormal CRI at 2 weeks, they're 6.8 times more likely to develop excessive crying, colic, and this is 93.1% sensitive with only 33.3% specificity. But if you've got a crying baby, it's pretty impressive to see someone use these techniques to make the baby quiet. So dysfunction occurs when motion is restricted, like elsewhere in the body. And as you can see, there's another depiction of the sphenobasilar synchondrosis, the SBS, so the sphenoid and the occiput. Named for direction of the freer motion, and so for cranial dysfunctions, these are named relative to the SBS. SBS strains include, again, physiologic and non-physiologic traumatic strains. You can have flexions, extensions, torsions, side bending and rotation of those bones, and as the traumatic vertical, lateral, and compression shears. So we diagnose these by using the vault hold, which allows you to use your palpatory skills to judge the relative location of the sphenoid to the occiput, and that is how we diagnose these. So there are different holds that you can use, and there are depictions of all of those. And yes, the sacrum comes into play, and so yes, you do palpate in sensitive areas when you're doing OMT. This is something that you talk to the patient about beforehand, and of course, in psychiatry, you would not want to be touching every patient in this way. You would be very particular about how you go about diagnosing and treating if that's what you plan to do. And there is one psychiatrist that I knew of when I was in medical school that did regularly do OMT on his patients. So it is used. So there have been positive clinical outcomes for pain reduction, change in autonomic nervous system function, and improvement in sleeping patterns with cranial OMT, as well as a lot of research recently done into chronic fatigue syndrome and the cause of that, or the etiology of that, being proposed as a neurolymphatic congestion. So treatment with cranial OMT has resulted in symptom improvement in these individuals. Indications for treatment: childbirth, physical trauma, dental work, or just having an abnormal CRI. Contraindications would obviously be things like an intracranial bleed, increased intracranial pressure, skull fracture. Relative contraindications: seizures, dystonia, TBI. TBI is relative, obviously, because you can have some of those other more absolute contraindications associated with that. However, it is also a good treatment for patients with TBI who have low CRIs. So, complications can include headaches, tinnitus, dizziness, alterations in heart rate, blood pressure, respiration, or GI irritability, which really speaks to the power of manipulation of the cranium if it can cause those types of side effects. So I want to talk about the venous sinus technique, which is one of the craniosacral treatments. It's got 4 steps to address 4 areas: confluence of sinuses, occipital, transverse, and superior sagittal sinuses. So the purpose of this treatment is to increase venous flow so the blood can exit via the jugular foramen. And this is a gentle, direct spreading of the sutures. So just to refresh everybody on what we're talking about here. So the first step, there you see the operator with the middle finger at the inion, and gentle lateral traction is applied until you can feel the response, the tissue softening. The same at the occiput sinus, only using 2 or 3 fingers aligned at the inion. And then again, you're waiting for that softening to occur. The transverse sinuses are released via the nuchal line there, so you put your fingers around that area, and the weight of the head actually adds enough pressure. You don't really have to give any pressure, and you maintain that until you feel the softening. And then you move to the superior sagittal sinus, where you gently separate the lambda from the lambda to the bregma, the sagittal sinus, using your thumbs. And then the superior sagittal sinus, a further treatment by placing the fingers along the metopic suture and separating those. So next we'll talk about CV4 decompression. This is the nifty trick that makes the crying baby quiet. So I paid attention to this for sure. The purpose of using this is for headache relief, reducing edema, relieving congested sinuses or lungs, general fluid exchange, resolution of secondary somatic dysfunction, or reduction of trauma effects. So the resolution of secondary somatic dysfunction is sometimes you'll find a dysfunction in another area of the body, and you'll treat it, and you'll reassess, and you'll find that your treatment did nothing or next to nothing, or didn't give you the response that you anticipated. And sometimes it won't until you go up and you check everything, and you check the cranium, and you find out, oh, there's a big dysfunction here. I've got to treat it. You treat that, and then you're able to effectively treat the other area. So again, the body's a unit, and if you don't remember that, it will remind you. So compression of the 4th ventricle is what goes on in this technique. And as you can see there, the hands are cupped, and you have to be very careful about where you place your thenar eminence, below the superior nuchal line on the occipital squama, medial to the occipital mastoid suture. And the head rests on the thenar eminence, not the thumbs. To monitor the PRM, extension is facilitated, and gentle resistance is given to flexion of the cranial bones. The still point is what you're looking for. That's what it's called. And it's achieved when the fluctuation of the fluid's no longer felt. You can feel warmth. You can see people sweat. Some people will laugh or cry even. It's not unusual to see some sort of emotional response in this situation. Um, Sometimes you can pick up on respiratory changes or other autonomic changes. And then you maintain that position until the normal cycle returns. So another technique used in cranial treatment is the V-spread. And the purpose of this is to restore motion of impacted sutures. So it's essentially just a gentle separation of the sutures. 2 fingers on one side, 1 finger on an area that is contralateral so you can monitor the fluid. Another technique is lateral fluctuation, which is a very good calming technique. And this is gentle shifting of the CSF to aid in natural movement of the fluid. Again, something that would probably be pretty essential in treating chronic fatigue or something like that in a patient. So you focus on the fluid motion in this technique, and you repeat until the fluid shifts without assistance. And the still point is, again, what you're looking for. So common questions. How are osteopaths different from chiropractors? We are different. We have different training. Chiropractors are not licensed physicians. They have no residency training, no surgical or pharmacologic education. And I found out in this process that there are some chiropractic schools that don't require you to have a full bachelor's degree. So I thought that was interesting. Scope of practice includes diagnosing and locating misaligned or displaced vertebrae, and through manual manipulation, the adjustment of the spine. So they're pretty limited to that area. And they mainly use the thrust techniques, like I was talking about earlier, the HPLA with the crack or the pop that people get really excited about. So there are a lot of differences. Where can I get OMT? Well, doctorsthatdo.org is a good resource if you're looking for a DO, period. But there are some in the area, not as many as we would all like, but 2 locally and then 1 practice that is in Versailles that I know of, that's all they do, Dr. Moore and Dr. Vick. Can MDs get educational exposure to OMT? Sure can. The American Academy of Osteopathy is very good about offering CMEs that start with the basic stuff. There's a convocation that's really great to attend if you're that interested in it. I would certainly recommend it. Dr. Griffin was the first one to pull me in to go into that convocation, and it's a lot of fun. It includes an evening with the stars, so you get to meet all of the kind of famous osteopaths and some of the older osteopaths it's a neat experience. So who are the DOs in our program? We have 4. Courtney Allen, Juan Pablo, Kara Curry, and myself, and we all come from different schools, so we all have slightly different training, but we all have the osteopath connection. There are my references. There's my study buddy from back in the day, Nita. She's in Oklahoma now, but I thank her for all of the hours that she let me practice on her. And I also wanted to demonstrate how small our world kind of is, because there you can see I was taught by Dr. Stiles. Dr. Stiles worked with George Laughlin, who was A.T. Still's grandson. And so in that way, pretty direct education experience there. I want to thank the people at KYCOM who were so fantastic to me and teaching me all of these things. And I want to thank my mentors going through this process. It's been really fantastic. Are there any questions or comments? Oh, I would say that it is more common to not. I know that, like, I personally, my intern year, manipulated a patient on the unit, one patient who, uh, she was very traumatized, and then on a medicine rotation, ended up treating someone at the VA who probably really didn't need to be admitted to the hospital. But the psychiatrist that I know of in Arizona, I mean, he regularly manipulated his. It was part of, treatment. I think there are a lot of liabilities that come with that. I certainly would not recommend manipulating every patient that you have, but there are definite indications, especially in a lot of the traumatized patients. When I was working as the fellow in Pikeville, working in the clinic and teaching, I regularly had patients who had fibromyalgia that would come in, and so that was a very popular indication, I think, in our clinic. Dr. Casey. So we are licensed in every state, the ones that are trained and educated in the United States. Now, I do know that there are osteopaths internationally. They are not, it's my understanding, unless this has changed, they are not able to fully license in the United States if they're trained outside of the United States. They're only able to license for manipulation. And I know that because there was an English doctor that had come over and taught down in Lecom, and that was essentially all he could do from being an outside. But there's in more areas like Pennsylvania, Michigan, those areas are really heavily populated with DOs. Ohio. In this area, it's not as easy to get manipulation. I would say it's probably fairly difficult. I know that the guys that practice in Versailles, last time I talked with them, they had like a 6-month waiting list. So I don't think the waiting list is that bad in Pikeville if you were trying to get manipulated, but Pikeville's kind of a drive. Dr. Whitman?
One of the things that I've always thought was good about osteopathic medicine as opposed to the failure of current allopathic medicine, touching the patient, actually doing the things that are being done. You can call certain people in the hospital that say, oh, so after you do your MRI and blah, 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 6 months come over, send you for further tests on these things. And also, the other failure of allopathic medicine versus failure of primary care. And many PO docs, because of the have a predisposition of more often both of them.
Mm-hmm. And I will say that part of my educational process is we were encouraged not to do things like labs that were not necessary. Now, I think that kind of stuff gets done. If you're in the hospital, you're going to get a CBC every day or what have you. But we were taught to not do that for many reasons, expense. We were very much encouraged to really have a specific question that we wanted answered by whatever imaging or lab or what have you that we were doing. So I don't know if that's necessarily done in allopathic education. In Europe it is. Okay. John? Well, I think when you look at somatization and how often that probably occurs, and we don't even really realize that it's occurring or can't prove that that's the cause of someone's symptoms, I think that there's certainly a lot of emotional relief that can come from, like Dr. Lippman said, even just being touched, even if it's in a professional, palpatory way. When you're someone who is isolated from that, it can have a big emotional connection for you, a response. And so like I was saying earlier, you want to be careful which patients you touch. You certainly, in psychiatry, can't do that with all of your patients.
Is the teaching in osteopathic technique also about boundary issues?
Very much so. Yeah. That's part of the basic training in this field is, that's something they give you up front. It's kind of a preface to the rest of everything is, there are certain patients where this is going to be more appropriate than others. Certainly talking with the patient so they understand what's going to happen and a professional way to go about palpating certain things like the sacrum or the pubic symphysis. That's another kind of touchy area where you explain yourself fully before you do any palpation, of course. With manipulation in general, well, when we talked about the cranial stuff, the list of side effects that can occur from that, when you think about the structure of what you're manipulating, the neural elements of it, if you do it right, you're supposed to have a good outcome, right? If you do it wrong, you can imagine the numerous possibilities that can occur. You can give someone a somatic dysfunction if you do it wrong. Certainly, I know when we were learning cranial stuff, there were some people who left with headaches simply because their partner didn't know how much pressure to put when they were just doing the bolt hold trying to diagnose something. So, I mean, it just really depends on how good your operator is. Anyone else? No? All right, thank you for coming. I was going to say it was really short. Yay, thank you.